And another thing that if we discussed like before about what's the preferred approach, what's the preferred transducer, again, in the adult world. So like this study suggested that the paramedian is superior to the midline and the curve is superior to the linear probe, right, in like finding your landmarks. Regarding the pediatric, so like always in pediatric, we may be a little bit behind. So some studies show that you can definitely use point of care like to find your landmarks, like to find your intraspinal space and to determine how the measurement changed in different positions. One study showed that again, that the best, the intraspinal space is maximized when the patient is sitting up. So I'm guessing this is why our textbooks like suggest that, but I will show you a different study that like shows like to put the patient in lateral decubitus as well. And this study also show like if you flex the neck, it doesn't change the intraspinal space, so you don't need to do that. Just if you were wondering. Studies in neonates show that again you can detect the level of the conus as well to evaluate reason for failed LP attempts. Regarding like failed LP attempts, so one of the studies that actually Katie spoke about it last year. So like it's some case reports of, and they suggest to use color Doppler before you do a NLP, because like they have two baby, one of them with bloody tap, one of them like didn't end up with bloody tap, and the one that had a bloody tap, when they put some colors to see why, so they noticed he had some blood vessels like on the way of the needle, right? So they shows that maybe you can even use the color Doppler, right, to appreciate if you have any blood vessels on your way. Right, so again, some blood vessel on the space. So then you can choose like a different space to poke. What about more advanced research? So like a study with 26 patients that was done on infants like until the age of 1 showed no significance between the point of care group, like landmark approach versus like the traditional approach. What about the like teaching how to find your landmarks? So that's again a nice study that was done in 2016. Again, all the quotes that I'm taking from like the summary of the evidence, it was published in 2016. So this is the one that was published after. So that included the study. So they try to realize like how much time or how much scans you need in order to achieve competency. So they took like 5 fellows. The mean age was 11, but as you can see, there's a broad difference like in the age between 3 to 20 and also in the BMI, which is the mean was 20, but there also were patients of 37. And the mean attempt for like the fellow, it's 14 plus minus 3, it's not 3 plus minus 14. The mean time to do it was again 72 seconds plus minus 40, so like between 2 to 3 minutes. And they have 2 experts that appreciate each and every scan. And they achieved the bar as like 80% success, but unfortunately for them, their fellows only reached 75%. So they concluded that in order to achieve competency, you need, let's say, more than 14 plus minus 3. You need maybe 20 or above. That's where the calculation. So like in the summary of the evidence, which I think for us, maybe like it's, I will say it loudly so Jason will hear because he's the one of the writers, maybe it's one of the Bible right now because like that's summarize all the evidence in pediatric point of care. So this is what he summarized about the chapter of like point of care LP. So today there are no large RCT to investigate the effect of point of care on success rates, complication, cost, patient flow, or patient satisfaction related to LP. Investigation are needed to determine the comparative effectiveness of statics versus dynamic techniques of the point of care. So that again was published in 2016. After that, maybe we have some research that maybe can change the picture. So, and it was even discussed in one of our journal club just recently. So it was published in some unknown magazine that maybe you know, Annals of Emergency Medicine in May 2017. And they did a big RCT of like point of care ultrasound, right? Like the static approach versus the traditional approach. And so again, they took 128 babies, and eventually their primary outcome was like a successful first attempt. And they defined like a failed attempt as a bloody tap. And what did they find out? So they found out that on the point of care arm, all right, there was 58% success versus 31 success on first attempt, so 27% differences. And success within 3 attempts was 75 versus 44, so again, a difference of 31. So they concluded that point of care site marking improved infant LP success in their hospital, and they think this approach has good potential to reduce unnecessary hospitalization and exposure to antibiotics in those kind of population. And for them, like for each and every 4 patients, the bedside ultrasound was able to spare like 1 additional successful lumbar puncture. And the editor of Annals also impressed, and he concluded that this study suggests that point of care can improve infants LP, although it remains to be seen how generalized the results are. That's for that. What's the potential pitfalls? So actually I tried to look like any evidence for potential pitfalls. So again, the only thing that I was able to find are some statements from this proof of the evidence. So their potential pitfall were like misidentifying the transverse process at the spinal process. As a result that you don't put your transversum in the right place, mistaking the spinal cord as the CSF. And that means probably you weren't able to identify like the conus medullaris as where it starts, where it ends. And without any connection to point of care, some failure to observe the usual precautions and recommendation of NLP. So to sum things up, that's my take-home message to you. So point of care LP, yes or no, believe it or not believe it. So at least that's my approach. Like I don't care how much literature there is or there isn't. If we're not going to try it ourselves, so we will never know. I was trying to find how many LP scans recorded on our QPad during our years. Anyone want to guess? So it's since 2011, I think. That's the date. We have 9 scans of an LP or system. 3 of them is actually not an LP, just by mistake. So technically we have, I think, 6 or 7. So, and why is that? Because we don't do it. Do we need to start doing that? So I believe that we need to practice ourselves. So we will be efficient, like in finding a landmark. So if we will need to do it, we can do it. I think like a little bit like maybe like all dogs. That's hard for us like to be taught new tricks. I even compared it in my head like maybe to direct versus like indirect intubation. I think everybody were taught direct. So when I was first introduced with the glidoscope, like what is that? Like I hate video games. I don't like this machine. I prefer my direct approach. That's what I've been taught. And like again, each and every one that finished pediatric residency probably did like more than 100 LP in his life, never used the ultrasound machine, and thinks that he's pretty good in that. So why do I need like to make things more complicated? But I have to tell you that, like I started in the beginning of my lecture, I became more a believer, right? And maybe like when people did like just blind central lines before, in some hospitals they still do it, and now like the standard of care is to do it under point of care guidance. So maybe if we'll have more evidence, we will start to use it. So I think for me, in the meantime, I think I will start use it, but I think like we need to choose our patient wisely. So the obese one, the one that maybe already failed like once or twice, and maybe during our scanning session just to practice, to find a landmark. So if we will need to do it, or if we want to do it, we will be able to do it like efficiently. So that's it for me for today. And you can find me on Twitter as well, apparently.